Good afternoon. This is a case of adrenal myelolipoma. I am Santosha. This is Himaja. We are from Osmania. A patient, a 22-year-old phenotypic male who is a resident of Mushirabad and presently unemployed, came in with a complaint of abdominal pain for the past 6 months. History of present illness. The patient was apparently asymptomatic 6 months ago. He developed pain in the abdomen, in the flank regions of both sides, radiating to the back. It was insidious in onset, progressive in nature, intermittent, once in 3 days, with each episode lasting for about 2 to 3 hours. Gripping in nature, there was sweating during the episode, and the pain subsided on medication. No history of vomiting, hematemesis or melena was seen. No history of fever or anorexia. No history of diarrhea or constipation. No history of frequent or burning micturition. Past history, he had a history of episodic weakening of both lower limbs every 3 to 4 months since 8 years with no sensory loss. The episodes lasted for about 3 to 4 days with complete recovery, and they aggravated on physical activity. He was previously operated for gynecomastia. Bilateral subcutaneous mastectomy was done 8 years ago. He's not a non-diabetic or hypertensive. No history of asthma, tuberculosis, seizure disorders, thyroid or allergy. No history of abdominal trauma. Birth history. Born out of second degree consanguineous marriage, second in birth order. Genital ambiguity was noticed at birth, but no further evaluation was carried out because of low socioeconomic status. Postnatal history, no history of failure to thrive, no neonatal hypoglycemia, vomiting, salt-losing crisis or hypotensive crisis. Hyperpigmentation was not seen, no accelerated height gain. Developmental history, normal scholastic performance was seen. Secondary sexual characters appeared at about 12 years of age. Developed bilateral enlargement of breast between 10 to 12 years of age. Menstrual cycles began at about 12 years of age, 3 to 4 days per 30-day cycle with minimal flow. No history of dysmenorrhea. No history of headache or visual disturbances. Family history not significant. General history, he was conscious, coherent, cooperative, and no signs of pallor, icterus, cyanosis, clubbing, or lymphadenopathy was seen. The patient has low set ears. No midfacial hypoplasia was seen. No goiter was seen. Bilateral well-developed nipples and areolae were seen. Scars of gynecomastia section were seen. Height is 146 centimeters, and upper segment lower segment ratio was normal, 0.94 by 1. On recording the blood pressure, we found it to be 130 by 80 mm of Hg. So the patient has a pre-hypertensive state. Then per abdomen was soft, no tenderness was present, no palpable mass or organomegaly was noticed, and no inguinofemoral hernias were found. External genitalia, incomplete fusion of scrotal folds was seen, no well-formed rugosity, no palpable gonads. Phallus length was 3 centimeters. Penoscrotal hypospadia was present. SMR, axillary head positive, pubic hair was developed, breast development was seen. These are the scars of gynecomastia section and the well-developed areola and nipples seen. The external genitalia. Provisional diagnosis, we think after examination, it may be a 46XX disorder of sexual development as indicated by bilateral development of breast, attainment of menarche, and absence of palpable gonads. Investigations, CBP showed no abnormalities, liver and renal function tests were normal, karyotyping was found to be 46XX, serum electrolytes, sodium was normal, potassium was decreased, ultrasound abdomen showed bilateral suprarenal masses, female internal organs, uterus and ovaries. CT abdomen showed bilateral inhomogeneous, predominantly fat-containing mass, lesion arising from adrenal glands, left greater than right. The mass lesion showed very minimal peripheral enhancement. The left one measured 11.2 into 11.4. The right one was smaller, 2.4 into 1.6, suggestive of adrenal myelolipoma, or it could have been an adenoma. Left ambiguous external genitalia with female reproductive organs. MRI pretty much confirmed the CT findings. It also showed uterus anteverted and no obvious evidence of testes. External genitalia, elongated urethra, hypertrophied clitoris, and prominent fatty tissue are on the urethral orifice. Hormonal assay, serum cortisol was normal, aldosterone was normal, slightly on the higher side. Plasma renin activity was decreased. Serum 17-hydroxyprogesterone was elevated a bit. Serum testosterone was higher when compared with females, but for the male reference age, it was a bit decreased. Serum DHEA is elevated. We could not do a 11-deoxycorticosterone level because of non-availability of ACTH. Clinical diagnosis, the patient has 46XX DST due to congenital adrenal hyperplasia, maybe due to 11-beta hydroxylase deficiency. The patient also has bilateral adrenal myelolipoma, left being larger than the right. Treatment is presently on tablet Hisone, and potassium supplementation was given to correct the hypokalemic state. We are considering unilateral left excision of the left adrenal mass, and then putting the patient on follow-up to see if the right mass grows. If it grows, we are considering excision of that mass as well. Histological confirmation of adrenal myelolipoma is to be done. As the patient was raised a male, oophorohysterectomy is being considered. The patient wants to be put on hormonal therapy. He wants to be a male. Thank you.
What's the diagnosis? Congenital adrenal hyperplasia. What is the most common cause of congenital adrenal hyperplasia?
21 beta hydroxylase deficiency.
What is the common presentation there? Why is the patient presenting with episodic weakness? And also patient has got potassium which is low. Is it common in congenital adrenal hyperplasia?
No, it's not common. Generally, CAHs we have hyperkalemia, salt losing crisis, but here we have hypokalemia. The episodic weakening may be periodic recurrent paralysis due to hypokalemia. We think it's 11 beta hydroxylase deficiency because there, due to excess of 11 deoxycorticosterone which has aldosterone activity.
What is the blood pressure here?
Blood pressure is 130 by 80.
But will it 11 beta hydroxylase deficiency, will it explain that it is due to this? Usually they are hypertensive. They'll have
Usually
hypertensive. Hypokalemia will be there, isn't it?
Yes, sir.
They don't have hypertension.
But,
and then do you think that I feel it is only 21 hydroxylase deficiency, and then now what is the connection between the adrenal hyperplasia, congenital hyperplasia and the adenomyelolipoma? What is the connection?
This is an untreated case of CAH, so maybe adrenal myelolipoma developed due to that.
So that means the adenomyelolipomas are functional here?
No, they are not functional.
They are not functional.
They are not functional tumors at all.
So do you think that 11 beta hydroxylase deficiency is the cause here?
Yeah.
Huh? So it's a, what is the karyotype? 46XX?
46XX.
So it's a female case presenting with virilization, but you don't have hypertension, but you've got hypokalemia. But you should have done other things, like when the patient has got hypokalemia, adrenal myeloma is there, that what about the catecholamine things and all? Not done. Any sort of paroxysmal hypertension is happening?
No.
Don't know.
No, sir.
So did you talk to the patient?
Yes, sir.
What is his approach? Like he wants to be, since he wants to continue as male or a female?
He wants to be a male only, sir. Actually,
In that situation, what are the procedures planned for?
for a hysterectomy has to be done to remove the uterus and fallopian tubes. Then he has to be put on this testosterone supplementation.
Suppose adrenal myelomas are removed and then the potassium normalizes.
Okay.
You know.
That will be a problem.
Okay. So still it's not clear whether you're dealing with a 11 beta hydroxylase deficiency or the entire electrolyte disturbances as a fallout of some tumors there. Evaluation is not complete, right?
And even histological
And yeah, it's a good case,
confirmation
right?
has to be
Thank
done.
you very much.